Welcome to the Insight program here on PEGTV. My name is Laura Vian, your host, and today we are going to be talking about the very popular topic of healthcare. Healthcare in America accounts for about 18% of our country's gross domestic product. Waste and fraud are estimated at about $1.2 trillion a year, and we're in the middle of a massive systemic change that's increasing costs by, well, upwards of 7% a year. That's going to affect us nationally, it's going to affect us on a state level, it's going to affect us on a local level, and most important to each of us, it's going to affect us on a personal level. So please welcome our guest today, Tom Huebner, who is the CEO and President of the Rutland Regional Medical Center, who we hope is going to give us a little bit of clarification on what this all means. Welcome, Tom, to the program.
Thanks, Laura.
And here to talk about all of this with you is our panel, Alan Keyes from the Rutland Herald, welcome.
Hi.
And of course, Polly Lynn, who is with the Mountain Times. And we're going to try to sift through a little bit of this in the next 30 minutes and kind of hopefully give you a little bit of insight, a better understanding of what's happening here and how it affects all of us, our local hospital, and our medical professionals. So tell us a little bit about, I guess let's just start. What's going on in the medical community? We hear a lot of stuff in the Herald and the Mountain Times about Montpelier. What about here?
Oh, nothing much. It's kind
Not
of quiet
much,
and
yeah.
boring.
That's why you had time to come down
sleepy,
today,
yeah.
right?
Not at all, actually. There's an enormous amount of change going on in healthcare right now, and the key underlying factor is really cost. There's the issue of having people insured, certainly is a big element as well, but the biggest one is cost. Most people, including me, believe that healthcare has gotten to a place where it costs too much and really the country can't afford it. We see it most in the federal deficit. The federal deficit is probably the most important element in all of the changes that are going on now. Medicare, which is the insurance for people over 65 and for the disabled, is 100% federal money. Medicaid's in Vermont is 55 or 60% federal money. There's going to be less of it, and that is driving a great deal of what's going on. Exactly where it's going to end and how much we're going to have in the end, that's a lot of speculation.
Sort of a no-brainer? I mean, we've known for years that Medicare reimbursements have been shrinking and Medicaid reimbursements are even worse. Did we not foresee this coming, that you just cannot operate a business when the revenues are coming in lower than the cost of doing business?
Well, but the federal deficit is, at the extent it is a relatively new issue. And the year 2000, which is actually not that long ago, there's a federal surplus, believe it or not. Remember the good old days of federal surpluses? Since the Iraq War, the federal deficit has just exploded, and Medicare is a component to that. And underlying that trend is the fact that not only is Rutland and Rutland County aging and have fewer young people, but the whole country is. And sort of the financial underpinnings of Medicare have gotten weaker in the last decade, and that's really accelerating the conversations about the deficit and cutting healthcare spending.
Has this affected me as a consumer yet? Is this all just in the planning stages so far? And when will it affect me as a consumer?
Yeah, that's a great question. It's affected you a bit. You may not see it as a direct relationship, but Medicaid has underpaid the worst for many, many years, as Laura's indicated. Medicare underpays as well, and they're beginning to catch up with Medicaid. Two impacts. One is it means we now overcharge everybody else, Blue Cross, Cigna, MVP, the other insurers, in order to make up the difference. Medicare and Medicaid pay less than cost, and Blue Cross, MVP pay way more, like a third more than cost. That means your health insurance premiums, if you're on that side of the world, that if you have private insurance, are much higher than they'd have to be if the government side paid less. The other thing we're seeing in Rutland and across the country is physician practices are changing. Physicians, because of cuts in reimbursement, can't retain private practices any longer. And in many areas, certainly in Rutland, that's meant they've come to the Rutland Regional Medical Center for employment or for primary care doctors, particularly to the community health centers of the Rutland region, federally qualified health centers. That's changed the basic structure of the provider community in a very, very significant way. Underlying that is that reimbursement issue.
So that means the hospital now is sort of in a different business of managing all of these practices too. I mean,
Yeah.
before it was the hospital and the doctors with their own business taking care of their patients. Now you've got this conglomerate of businesses that you have to manage.
You're quite right.
Financial, the billing piece, the HR piece.
All the regulatory issues. 60% of our business now, roughly, is not inpatient care. It's all the outpatient services, including all those physician offices. People think of hospitals as beds. Really, that's not mostly what we do anymore. And that's not, again, we're not unusual at all. So it's very much changed the nature of our work.
And with the decreased funding that will be available to you, or that is increasingly available to you, which part of the business do you think will suffer from that, or how are you going to make up the difference?
Yeah, we're going to have to become more efficient. Well, there's two ways this could go, though. Let me back up. So one possibility is they just pay us the same method they've always paid us, but less money. Fee for service, which is, you do one more lab test, you get paid one more dollar, however many dollars it is. And there's this whole incentive to do more and more and more and more and more. If they pay us less for each of that, it's really not a very attractive option, at least to me, because you're sort of having to do what you always did on the cheap. The other alternative is really changing the incentives on how we're paid and moving away from fee for service to some kind of payment per capita per number of people in our area, or some kind of global budget that we need to manage within, so that we are incented to find efficiencies in the care and get, frankly, unnecessary care out of the system. I'll give you an example. We've been doing a pilot on congestive heart failure patients. Tend to be elderly, pretty frail folks. They're very sick. The national rate of readmission to a hospital of that group of patients, this is the national rate, is 25% within 30 days.
Wow.
So a quarter of them are back in the hospital again within a month because they're so sick. We believed that if we really manage that care well across the spectrum with our cardiologists and with our primary care doctors, in collaboration with the home health agencies and the nursing homes, that you could get that rate down. For the last 6 months, our readmission rate's been 12.5%, half the national rate. That's a real savings for the country, the community, and it's better care. Now, one of my cardiologists said to me one day recently, Tom, is the hospital financially better off right now for that? I said, no, actually, we're worse off. But we have to begin learning how to do that, and we've chosen to pilot in those ways. I'd rather have that kind of system where you change the incentives so we can get care that's really not beneficial, if you can really get that coordination at a high level and get that kind of cost out first. Patients are better off, and you really do save the money.
So is the Health Connect going in that direction?
Health Connect is sort of unrelated.
Okay.
The Accountable Care Organization,
Yeah.
which was formed by Fletcher Allen and Dartmouth, which we're part of, is just for Medicare initially. It's not every patient yet. That is aligned with that and trying to move towards a more capitated global budget approach.
Okay. Are they seeing similar successes?
Well, it's just begun.
Oh, okay.
It's just begun. It's too early. And there are other foundational pieces that are in place. We have something called medical homes in Rutland County. 75% of the population are in what are called medical homes now, which have some incentives to do some of that work as well.
What are some of the medical homes? And talk to us a little bit about that, because that's a national trend now.
It is, and Vermont's at the very leading edge of it.
Right, and what that means to a patient compared to what it would have been like when we typically made a visit to our doctor.
It's a great question. So all of the community health center of the Rutland region sites are medical homes. So that's Castleton, their Rutland sites, pediatric, what was known as Pediatric Associates, Paulet, Brandon. In addition, Dr. Coombs and Dr. Bullock and Drs. Hogenkamp are all considered medical homes now. They're given additional funds to really have the resources to actively manage particularly chronic diseases, to stay on top of your diabetes, your congestive heart failure, whatever your chronic disease might be. Along with their resources, they've been given, resources have been given to the hospital to form what's called a community health team, to make sure those people are getting to their follow-up visits, to help them do that, to make sure all the gaps are being filled between the different providers, to do social work and nutritional counseling and that kind of thing. This has happened across the state of Vermont now. It's been really building over the last 4 or 5 years. We're just beginning to see real cost results.
So, and it's because the people with the chronic conditions that you mentioned, the congestive heart failures,
Correct.
the COPDs, the diabetes,
Exactly.
those are the folks that are costing the healthcare system the most money. So that's why you're trying to
That's where the
manage
focus
them.
is there.
Right.
Exactly right. I mean, the hypothesis is they provide about 80% of the cost in the system. If you can do a better job managing the chronically ill, you can really do something important. So this is a statewide initiative. Rutland's right in there with it. We see that as a very foundational piece of where we're going on the delivery system side. Now the exchange, what are they calling it now? The
Health
Connect?
Connect.
Connect.
Health Connect. That's a way of getting people connected to health insurance. Right now, the health insurance is still fee-for-service. It's still the old style. It may or may not help more people get covered, but it really doesn't change how care is rendered in a doctor's office or in the hospital.
So if more people have access to insurance, can the system meet the demand?
Well, that's a great question. So we'll all find out. First, whether there'll be more demand. Vermont was actually doing pretty well with having people insured before Act 48, which put in the exchange, came about. Catamount Health, which was, gosh, early 2000s, I forget exactly which year, really filled a lot of gap, and Vermont's uninsured rate nationally was very, very low compared to this. Now, this has the promise of taking it even further. We'll see if that promise is realized or not.
So with this Health Connect with the exchange, we
Yes.
have 2 insurance companies that people can choose from?
At least 2.
At least 2.
There-
So then we can expect more insurance companies maybe doing business in Vermont
No.
through the exchange? No, we can't.
The 2 that are approved are clearly in, are Blue Cross Blue Shield of Vermont
Right,
and MVP.
right.
There's a co-op, which is a newly formed entity which is allowed under the federal law, which is trying to get onto the exchange. They're in the process of getting their license so they could go on the exchange. I think that will be the limit. The co-op's a different option. Whether it's better pricing or not, we'll find out.
So by having these different insurance companies on the exchange, that allows for more competition, so that
No.
it doesn't. What does it do for the consumer? I mean, I have a choice, but what will that choice? How will that choice benefit me?
The actual level of competition is fairly limited because it's not really around price so much.
Okay.
So on the exchange, this is all in the federal law, there are different levels of common benefits, but there are not thousands of them. Right now you could buy any combination. You go to buy it directly, there's a zillion versions. There'll be 4, I believe, on the exchange, what they call the bronze, silver, gold, and platinum levels of care. And those 4 will have different prices. I believe the prices between the different carriers will be remarkably small because the benefits aren't any different. They'll be very, 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 very similar. And you'll be choosing mostly based upon, do you think that one provides a little better service? You know, you got somebody on the phone. If you have questions, it'll be around those kinds of things primarily. What it does, though, is it creates a larger pool, potentially, and that a larger pool of insured means costs can be coming down because it's across a broader group. Now, this is getting not too technical, but Vermont has been a community-rated insurance state since the early 90s. That will be more pronounced, that lowering of rates, in states that didn't already have community rating than it will be in Vermont, I think. So I don't think you're going to see a big change. The other big part of the exchange is if you as an individual are buying on the exchange, you can have that purchase subsidized dependent on your income. So if your employer is not paying for it, and small employers can buy through the exchange, if you're buying it individually, the cost will be dependent on your income. A lot of controversy about some of that because for some subgroups of the population, the cost actually might be a bit higher than it
Than
was
what it
with
was.
Catamount
Catamount,
out. So there's a lot, I mean, there's a lot of permutations,
Right.
a lot of detail in that, and I know some about it, but certainly there are people who are even more expert than I.
You had said something about here in Vermont, we actually have, I'm probably not going to say it exactly right, but you'll get my idea, fewer uninsured people than they do in many other states.
That's correct.
So how many people are we talking about that are actually uninsured? Do you know in
Yeah.
the state of Vermont? And
Vermont's roughly been about 9–10%.
9 or 10%. So most people are insured either, I would say obviously through a group employer plan versus
Or-
maybe an individual.
Or Medicare.
Or Medicare,
Or
Medicaid.
Medicaid, or
Okay.
Catamount.
Right, okay.
VHAP.
And so that Catamount plan is going to be completely disassembled.
Catamount's gone.
And
after
that
us
includes
January.
Dr. Dinosaur for kids as well.
Dr. Dinosaur
Is
for
that
kids
just-
is actually through Medicaid. It's a
Oh,
slightly different
okay.
variation.
So that
Again,
was
you can push me on the insurance side a little further.
Yeah.
I probably should go because I run a hospital. I actually don't run an
Yeah.
insurance
Yeah,
company.
yeah,
But so a lot of that will remain in place.
But they're so tied together. It's hard, and we
It is.
apologize for making
No,
you,
that's all right.
you know, giving you those kind of questions.
Trying
but
to answer 'em
Yeah,
as
and
best I
doing a
can
great
with it,
job.
yeah.
Where does Vermont rank as far as moving forward on health reform?
Cutting edge. Vermont is right on the tippy end of the sword on this.
Is that good or bad?
Yes. I mean, Massachusetts is probably a little further ahead of us on some fronts. We're further ahead in some other pieces. Blueprint's kind of a new idea. I mean, the blueprint, the medical home idea. Massachusetts really hasn't done that. They had a health exchange in place now for 3 or 4 years already. It's really what the federal system was modeled on. Hawaii's a little bit in the same place. So it's kind of, I mean, it's fascinating in some ways that we are trying these things. And in some ways, Vermont is small enough that it, you know, you can argue it's a good pilot. For those of us who have to make payrolls and take care of people, it's a little scary.
Are other people in the industry kind of that you talk to talking about what's going on in
Oh
Vermont?
yes, Vermont is on top of mind for lots of people. Whether it's the exchange or the proposed single payer approach in 2017 or beyond, or the medical homes. They had a medical home conference up in Burlington for Vermont last week. There are 500 people there. Half of them weren't from Vermont. They're from New Jersey and other states who are trying to learn about what we're doing, because in many ways, we are leading the nation in some areas. Again, a little scary too, because we don't really know how this is all going to turn out.
So as the CEO of a hospital, you're sort of treading, you don't know what's going to happen either. I know that you're a consulting director of the Blue Cross Blue Shield, but you're not really into that arena so much as you're looking at the hospital business and how we're going to serve the people of
That's correct.
our community in the best way with all of these variables going on from the federal level to the state to the needs of the people in Rutland County. I mean, are you concerned that we're going to meet the needs of medical needs of people here?
Yes. I mean, and you're not paying attention if you're not worried about it a bit. This idea of there being significantly less money, really to do more than we've been doing in some ways.
But yet doing it more efficiently, as to your example
if
of the
they give us the
congestive heart.
flexibility, right? That's my concern is, of course, that they're going to, you know, say, here's less money and we're going to talk about more flexibility, and it'll never happen because I've been around for a while. But so I do worry about that part. And there's some technical details within some of the laws, within the Accountable Care Organization law, for instance, where they don't allow providers to retain enough of the savings so that it, you know, destabilizes.
Where do the savings go?
Half of it goes back to the federal government. The problem is that a lot of our costs are fixed costs. We have big buildings and you have to have core staffing there. We know that they need to have some of the savings go back to them. That's, of course, proper.
Right.
But if it all goes back to the government, then you start worrying about whether the whole system is stable or not. So there's lots to worry about. On the other hand, I strongly believe the status quo is not sustainable either, and that we must lead, we must find ways through this. And, you know, there's a balance between being courageous about it, but not foolish, right? And that's really, it's very important stuff.
Could we see hospitals specialize in certain things or merge to help find savings?
I'm not sure you'll see specialization in Vermont, because really the location of most of the hospitals in Vermont are to take care of different geographies and be reasonably close to our populations. I mean, that doesn't mean every hospital will do everything. For Rutland Regional, I often say we can take care of about 80% of the healthcare needs of our community. 20% we need to send to a Fletcher Allen or to a Dartmouth because we're just not big enough to do them and it's not proper. And that's fine, and they should be specialized in that way. As to mergers, you're already seeing it. Central Vermont Hospital has merged with Fletcher Allen. Bennington did not merge with Dartmouth, but they have a strong relationship and their physicians are actually employed by Dartmouth. Plattsburgh Hospital outside of Vermont, but Plattsburgh merged with Fletcher Allen. So there are huge changes going on in the structure of that.
Is that possible to happen here in Rutland?
Everything's possible. Do I think it's likely right now? No. We are the second biggest hospital in the state. We are geographically distant from both. We're equidistant pretty much from Dartmouth and Fletcher Allen. We have very strong relationships with both. In fact, the chief medical officer of both those organizations sit on our board of directors. So we have their advice and counsel all the time. We are in their accountable care organization, which is a long way from a merger situation. But, you know, you do worry. If the costs and reimbursement are cut enough, could that make you have to rethink some of those things? It's always a possibility, of course. Never say never.
What does the timeline look like for you? What are your first challenges that you face, and then what do you think will be, you know, the ones to come sort of immediately following?
Yeah, I mean, we're already seeing the cuts in reimbursement.
Okay.
The so-called fiscal cliffs, we lost $3 million a year in reimbursement on January 1st. The cliff that was not supposed to happen actually affected us $3 million a year.
Wow.
Another $1 million a year went away on March 1st in the kind of the mini cliff that happened then.
Is that sequestration?
Yeah, the sequestration's the million, exactly right. So that's $4 million. We're also expecting actually no inflationary increase from Medicare for next year, you know, but our costs are still going up. We still have to pay salaries a little bit higher. And so that's a cut of a very kind of quiet type, but it's a cut nonetheless. Yeah. Especially Medicare. Medicare is half of what we do, so it's a huge part of it. So that's immediate. That's right now. That's already affected us. We're working on next year's budget. Our fiscal year starts on October 1, right now, to try to live within those constraints. The other piece next will be the health care exchange, and whether it's up and running on January 1st. We'll see what impact that has on us, whether the systems are really operational cleanly by then. They actually have to be operational by October because they need to begin enrolling people. I worry about that a bit. And then the Accountable Care Organization, which we are working with Fletcher, Dartmouth, our Community Health Center, Rutland Region Friends, to try to get that functional, just beginning. That work's going on right now. We're doing pilots like the CHF, we're doing medical homes. So some of those things we've been working on for the last few years. Even our electronic medical record, I believe, is a foundational piece for all this change. So there's a lot of work, foundational work, that's been going on for the last few years, and more to come. It's a very, very changeable time right now in healthcare.
And you're talking about getting less money, but you're also expanding some services at the hospital. It's a psychiatric unit, and you're getting into the methadone clinic as well.
I prefer to call it opiate treatment center, but yes. Yeah, there are services that we need to grow in order to meet our community's needs. There's no doubt about that. So psychiatry, we expanded the psych unit. It actually opened a week ago, a week and a half ago now, with the new beds. That was really as a result of Irene. As I'm sure people know, we now have what we call the South Wing, which we can care for the sickest psychiatric patients in the state, 6 of them. Not all of them in the state, obviously. Very important for us because we have people in Rutland County and our surrounding areas who need that care. And I really strongly believe that this kind of decentralized approach will be the best for patients. Frankly, I think it probably should have happened decades ago, but you know,
because they're closer to home,
closer to
family
home,
resources.
and we are Medicare certified, which the state hospital lost its federal approvals years ago. I think it'll be, frankly, better care.
What percentage of the population did you get out of
The state hospital was 54 beds. We're picked up six of those. They're not replacing all of them, so it's a little bit of harder math than that. They're replacing about 40 of them, I think, with acute services. So it's a little more complicated. Yeah. But we really felt strongly. We had the clinical leadership in our organization and clinical staff to do it. We felt we, frankly, had a responsibility to do it. We've seen patients waiting in emergency rooms for beds for days sometimes, including in our emergency room, because there wasn't a bed in the state of Vermont. So that's why we did that. Opiate treatment, probably no one needs to know why we're doing that, right? It's not subtle. We have a significant opiate problem in Rutland. There's no doubt about it. As I've strongly believed for many years, we need to have better treatment options, including methadone. But methadone in the context of a treatment center, which has counseling services and connect in with all the other key providers in the area. Our board approved are going forward with that. We're about to sign the contract with the state for an October start. Very, very important to us. Both of those are sort of, you know, you don't do them to make money, but you don't lose money on them either, is the expectation.
And where's the opiate treatment center going to be located?
Right down the road from where we're sitting today, here in the House Center.
So it's the same location as it had been?
Same location.
Yeah, okay.
Yep. So that's going forward, very, very critical to us. We see these patients in the emergency department and throughout the hospital literally every single day. We hope that we'll see a few less of them once this is up and running, and I think it's so critical for our community that this happened. It's the partnership with prevention and enforcement. As Police Chief Baker has said quite correctly, we need to be doing all three things. Right. We need to be doing prevention, we need to be doing treatment and enforcement as well. We got to all hold hands together to deal with this.
And when is the anticipated opening of
October.
It is October. Oh, okay.
Do you have an anticipated amount of people that you will serve?
Yeah, 400. Not on day one, but
is that like a year?
By the end of the first year, we expect to be at 400. There are 100 Rutlanders who are now leaving the area for treatment, driving often an hour and a half each direction every day, 365 days a year.
Where are they going?
They're going to West Lebanon and Burlington and places where there is treatment now. We believe that is a barrier to, and the health department believes it's a barrier to others who would benefit from that treatment. Some of them will be patients who are currently getting a drug called Suboxone. Methadone is a far better choice for them. And then some of them it will replace the drugs they're getting on the street. Right. And that is our fervent hope, and we all believe that 400 is where we'll be. Yeah. We'll all find out. Really.
Has Chief Baker brought you into this conversation? Oh, he's been on our show a couple of times, talking about creating partnerships and bringing. And so you've been working with him.
Yep, I was actually on the search committee for the police chief.
Oh, you were. Okay.
Good
choice.
I know Chief Baker, and Larry Jensen, who was chair of the police commission, worked for us at the hospital for 10 years before he retired. So
that's great. So that's moving forward. Yeah, hearing it from your perspective.
Yeah, it's absolutely. And it being Rutland, we all know each other already, and we have a very good working relationship with the Rutland City Police. We, frankly, need to have a really good relationship with the Rutland City Police.
Well, he tells us about the seriousness of the problem from the law enforcement side, and so you're just really kind of confirming the fact that this is what you're seeing from the healthcare side.
Ask any physician at the Rutland Regional Medical Center. I mean, emergency department's the obvious one. Pregnant, addicted moms. Soon-to-be moms is a huge issue for us. I mean, there's lots of issues that are very, very, very serious that we believe we can move forward and do a better job with, and that's why we've been so involved in the process.
Yeah. Well, Tom, our time's just about up.
How could that be?
I don't know. It was wonderful to have you on again, giving us this update. I think it's been about a year since you've come on the show. Anytime. And certainly healthcare is ever changing and moving forward, and we know what we read and hear, but it's nice to get it from the horse's mouth, giving us that little insight, which is what we're all about. So anytime would be great. You're always welcome.
Great.
Thank you so much for being on the program. Thanks for joining us here on Insight. I'm Laura Vian for Alan Keyes and for Polly Lynn. We'll see you next time here on the program.